Yeah, we're just going to touch base on low back pain. So seems like there's some maybe strength coaches here, some PTs, and then maybe just the average person. Oh, and then there's an athletic therapist. Um, so I think the overarching theme today, like Arash said, is going to be back pain. And I just want everyone to think about a couple things. Just know that back pain is one of the most common musculoskeletal problems in the world, and it's one of the main reasons why people actually miss days of work. They miss doing things with their friends and family, or just even going about their daily life because of back pain. Ask yourself if you've ever met anyone in your life that hasn't experienced low back pain. And if you haven't, please share, because I would love to hear how you haven't met someone with back pain. But I think an interesting thing that we can touch base on with back pain is that it's probably one of the areas that gets screening and imaging done way too often. Now, that doesn't mean that no one should ever get imaging done on their back, whether it's an X-ray or MRI. X-rays, they're pretty cheap and they're in place to rule out any real big, bad, and uglies or any red flags. So like if there's a fracture or if there's anything else crazy kind of going on. And same thing for MRIs, but for the average person that's pretty fit, that's healthy, that's moving on a day-to-day basis, and then they experience back pain after sitting in a car for longer hours than they typically do, they should not go get an MRI if they're experiencing back pain. So if you go to a doctor and they immediately want you to get an MRI, or maybe you looked online and you think that you should get an MRI, I would say think twice. You know, it may be better to go get screened and checked out by a healthcare clinician, such as a physical therapist, or a good doctor should refer you to a physical therapist if it's just occasional back pain. Or what you guys can do to check out is this article that we wrote for a company that we've paired up with called PeerWell. And I'm going to add the link here. So check out that article. Maybe you can check it out as we're going, and then I'll open up at the end of the webinar some areas for discussion and answering some questions. But that's actually a really nice article that I wrote for PeerWell. And to be completely honest, it's how I manage a lot of people when they first come into the door when I see them in physical therapy. The biggest thing is education. A lot of people come in, some of them have imaging, some of them don't. But they come in and they're really worried. I mean, back pain can seem scary. So big thing is education. And then that's likely what Mike is going to be touching base on today as well. But if there's any burning questions that you have about the article, let's talk about it at the end. So save your questions. I'll bring it up again at the end. And we can talk a little bit more, because the article is designed just to get people moving, to get things going, and to get the conversation started about how to manage your low back pain. Doesn't mean that that article is going to fix everyone and that everyone that has back pain is going to get better seeing that article. But it's a good entry point. So we can talk about that more down the road. And Mike's going to take over.
All right, guys. So as Arash said, we have a general outline of how we're going to run this webinar today. But by all means, please stop us if you guys have questions, if you guys have concerns, if there's anything you guys want to ask, just stop us, let us know, and we'll all chime in. But going back to what Craig said, I think the stats are I want to say 90% of Americans are going to experience back pain at some point in their lives. And I'm no different. I'm sure none of you guys are any different. Arash, Craig. I know for me, in college, I hurt my back 300 times deadlifting. The first time I couldn't lift, I shouldn't say couldn't, I didn't lift for 1 month. Second time I hurt my back, my sophomore year in college, I didn't lift for 2 months. And the third time I hurt my back was actually the year after undergrad.
I'm totally guilty.
Yeah,
I'm totally
guilty. See these pathologies, and you think you are these pathologies, when in reality, there's so many people that have these asymptomatic same issues that you have. So you can't just go based off the image.
I'm sure you guys have seen one of the articles that we wrote. It's titled "You Are Not Your MRI." I'll share the link right now. But this is a good read for later on if you guys haven't read it before. There's only 2 X-ray machines. So this is a connection problem. Are you guys having issues here? Shame. Ah, shit. Me too. I'm having connection problems. Damn. Raj, any,
You want to use we could come back in with.
All right, guys, we're gonna come back in. Give us 1 second. Oh, wait, a bit.
It's fine.
So you guys good now? Stop where you told you about your injuries in college. Okay. All right. So we're back. So I got injured in college 3 times. Didn't deadlift didn't lift at all for 1 month, 2 months, and 6 months after all my injuries. And I was actually scared of deadlifting. I didn't deadlift at all until I actually went to PT school, just because I was scared, like many people are if they injure themselves doing the same thing. We'll get into how to work around that fear and to get back into doing it. Okay. Hopefully this is working now. So I injured myself in late February. I was deadlifting. I've been deadlifting, for the last 4 years now since my first year in PT school, getting back into it. I've been working the program I was on. The day I hurt myself, I was supposed to lift, I think 4x5s at 325. I knew that was the program I had designed, so that's what I wanted to do. And this is where one thing comes up is ego. Ego and sticking to a program. That's where I really fell short in how I hurt myself. I think I was warming up. I was going through my working sets. I think I was only at like 215 or 205, and the back felt a little off. It felt weird. It kind of felt like it hurt, and I was like, what is that? I'm just going to keep going. Didn't really listen to my body, and it felt familiar to what I felt before in my back, but of course, it was only in my back. I used to have radiating symptoms the last 3 times I hurt myself. It was all the way down my left side, left butt, all the way down my left-hand side of my leg. So I kept lifting. I went heavy. I think I even increased the weight like by 10. I went to 225, which is just stupid. Lifted again, and right after that, I knew I'd hurt something. I was in a lot of pain. It hurt to bend. It hurt even not even bending, just standing still. Cut my workout short that day, and this was on a Friday afternoon. Went through the weekend fine. Woke up Sunday morning, and my back was feeling great. I was like, oh, it's feeling good again, I'm going to go to the gym. It was supposed to be my clean day. So I started doing clean, started with my working sets, felt good with the bar, felt good with 25s, felt good with the 45s. I was like, man, I'm feeling really good, man. I think I'm learning a lot more about my clean form, and I'm just going to go for 1RMs because it feels so great. My back didn't hurt at all that day, which is pretty dumb considering 2 days ago, my back was in a ton of pain. And even the day before that, it was in a lot of pain. So I went for 1RMs. I actually didn't feel too much that day. It didn't hurt. I was able to get through all of them, didn't miss anything. Then the next morning, Monday, I woke up. I was in a tremendous amount of pain, like 7 out of 10 pain, right in the middle of my back. The morning, so for discs, we'll go over discs and how they typically present, which isn't always the same for most people, but a lot of times it hurt more in the morning. So morning times was rough. Like by 2-3 p.m., I started feeling a little bit better. But the mornings were really, really tough. Any sort of bending really hurt. Sitting hurt. Bending forward to touch my toes hurt. Couldn't even bend down to touch my toes. Touching my knees really hurt. I'm lucky that I'm a PT and I don't have to sit too often. So I was up and I'm basically standing the whole time, moving around, which is really, really helpful. So that didn't affect me too much. But for people that have desk jobs that are sitting more often, 1 or 2 things that you can do if sitting is something that's painful. 1, try to stand as best you can. Try to work on a standing desk, or try to stand. If you're on a table like this, you can put shoe boxes, stack something up so you can stand. If you're not able to do that, and you do have to sit, try to sit away from your backrest. So you're almost sitting up, trying to somewhat arch your back, or put a towel behind your back. And what that's going to do is that's going to put your back in a little bit more of a straight or extended position, which for a lot of times for people with disc pain is more comfortable. Now, there's something that you guys might have heard that's called a directional preference. So for people that have disc pain, a lot of times they have what's called a directional preference, meaning that one direction hurts while the other direction makes it feel better. And typically, and this doesn't always apply by any means, flexion or bending forward is what hurts more. And the extension, you're going backwards, makes it feel better. For me, I fell into that kind of a half and half category. Like I said, the bending forward and the flexion really, really hurt. But going back didn't really help too much. There's an exercise that you guys might have seen on social media, or you might have seen other people say to do when you have disc pain, which is called a prone on elbows or a prone press up. It's essentially lying on all fours and pushing up on your elbows or pushing up on your hands, basically working on your back. If I'm laying face down with my head over here and my feet over here, going this way, kind of like I don't do yoga, but I think Cobra is that position, right? I think it's like doing a Cobra pose. That did not help my symptoms at all. So you'll see many times some people will prescribe prone on elbows or press ups, Barry McKenzie, like you said, Andy, but that didn't help me. So I didn't continue to do it. But for some, that's extremely beneficial and can really, really alleviate a lot of symptoms. In terms of like rehab exercises, I didn't do any quote unquote rehab exercises. So you might have seen people do motor control exercises, dead bugs, planks, anything like that. I did not do any, and there's a couple of reasons why. One, is the video still frozen for you guys? So you guys are fine? Okay. Hopefully it's fine for everyone. We're still working out the kinks with this system. Hopefully we'll get them solved as we continue to go on. It's not working for everyone. All good here. Fine here. Okay. Perfect. Where was I? So yes, I didn't do any rehab exercises, these low-level rehab exercises, for many reasons. One, I was very confident in knowing what my problem was this issue, which is why we always recommend that if you're in pain, to go see a physical therapist, because most importantly, they're going to give you the confidence and the knowledge to know what's wrong, and B, the best to manage a plan of care. Second reason why I didn't do anything was because I didn't find anything that worked for me. I went through different low-level motor control things, prone press-ups. Nothing seemed to make it better. It didn't aggravate my symptoms, but it didn't make it better. The one thing I did know for sure was that bending forward flexion hurt. So all I was going to do in these first couple days and week ended up being over like about a week for me, is I was going to avoid all flexion activities. I was going to try not to bend down. I was going to try not to sit. Sneezing actually didn't hurt me. Sneezing is very common for people with this pain to hurt. So I was going to try to avoid any flexion activities. So that brings us to rule number one. If you're in pain, for the most part, early on when it's acute, avoid the things that hurt. If flexion hurts and it's causing me 7 out of 10 pain, I'm not going to say, I think I need to get myself used to this and just do this more often. Avoid the thing that hurts, okay? When you're in acute pain is more directly linked to an actual pathology that we are in pain because of a certain thing. So you want to avoid that for the early time, okay? One thing that actually did help me a lot throughout the unit is, what's that little red stim thing that we have?
Oh, Power Dot?
Oh yeah, the Power Dot. Power Dot essentially is a fancy TENS device. We've written an article on TENS before. I don't want to go down too big of a rabbit hole, but basically what TENS does is it tricks your brain, certain nerves in your spinal cord, into not feeling pain. The way I like to describe this to people is that if you have a scale, and this is 0, and this is 100, and your brain is only able to feel in some range between 0 to 100, right? When we're in pain, we have all these different signals going into our brain. So on this 0 to 100 scale, maybe 90% of them are pain, and 10% of them are, oh, the water is cold, oh, the air is, moist, etc. When you're in pain, what we can do, and how TENS works is that it distracts the brain by overloading it with different stimuluses. So, when you put TENS units on, those little electrical simulations, they're found like they're pricking you, they're poking you, things are going up and down. Correct, Daniel, the gate control theory. Yes, David, it was the Power Dot. So I actually wore that at work for the first week, and it really helped me. And again, this is all going to, it's going to be variable for people, but essentially is that it's just tricking the brain. It's not fixing anything. It's not helping you heal. It's not helping things heal faster. It's just tricking your brain into not feeling as uncomfortable. So I wore that during work for that first week. About a week in, I started feeling a little better. I actually did take a break from the gym. I learned from my first mistake. Yes, there are modifications that you're going to make, which I'm going to cover now. But I said, you know what? I need to take a break because my back's actually in a lot of pain and everything really, really hurt. So I took a break off from the gym. Going back to the gym a week later, and it's important to continue with your physical activities as best as you can. Yes, there are modifications that I make. I still went to work. I'm still walking my dog, still doing things like that. But I was like, I'm not going to load myself up with too heavy loads right now because I already did that doing the 1 round cleans, and that wasn't the smartest thing. So going back into the gym, the best thing that you can do is make modifications to your gym program. You want to stay as active as you can and to try to continue to exercise, continue to stay active, continue to stay fit, but things avoiding that sharp, intense pain that I had in my back. So I'll kind of go through some of the modifications that I made, and I'm going to do kind of a screen share. We took some of the videos to kind of explain some of the different things that I changed with my different sets. So I'll first go through leg day. One of the first things that I did with leg days, I used BFR. BFR is blood flow restriction. And again, I'm sure you guys have heard us talking about this a lot. But what we were doing with BFR is we're completely occluding all venous return back to the heart. So we're putting a cuff on our arm, or for the leg, it's around the thigh. And then you're restricting a certain percentage of blood flow back to the heart. Now, why we do this? One reason is we're able to get hypertrophy at loads of 25 to 30%. Whereas typically to get hypertrophy, you need loads basically over 70% RM. So I knew I wasn't going to be deadlifting 325. I knew I wasn't going to be back squatting. I probably couldn't even back squat at that time. I definitely couldn't have. But what I could do is some of these other exercises, which I'll show you guys, at lower loads, and still try to maintain as much muscle mass as I can while I was rehabbing for my injury. And if you guys are interested more in BFR, we'll definitely do a webinar down the road on that. So again, I used BFR for just about everything I did in the first 2, maybe 3 weeks. That is the article reference that Jennifer had just posted, by the way. And for Alina, you should basically, when things are acute, I like to say in the first week or 2, you want to avoid really intense pain. Now, a lot of times when you are in pain, you're not going to know how your body responds to it until usually later on that day or even the next day. So it's hard. So if you might be going through your daily activities and you're like, I kind of feel the discomfort, but it's not as intense as I thought it would be. Maybe it's okay. And then the next day you're in a lot of pain. You might want to reconsider, might want to think that maybe what I did was too much for me at this time. Maybe the load was too high for me at this time. So that's when you want to cut back. But again, you have to be your own experiment because everyone's going to respond differently and everyone has different pain thresholds. You have to be able to judge what type of pain it is and make those decisions. And that's where going in with a physical therapist in person will help you make these decisions because we see people in these types of pain all the time and they'll help guide you through processes like this. So going back to leg day, deadlifts. I didn't do any deadlifts. No. Like I said, at the time when I went back to the gym a weekend, bending over still hurt. It wasn't like a 7 out of 10, but it was like a 4 out of 10. So if just bending over 4 out of 10 was painful, I wasn't going to load that up with more weight. So what I did to hit like the posterior chain, I basically did kind of like sumo squats. I used a kettlebell. And again, I was going light. And I had BFR on both my legs. I was doing things like sumo squats, doing things like a lot of single leg exercises, a lot of lunges, a lot of step ups, a lot of single leg RDLs, a lot of staggered RDLs. And I'm going to try to do a screen share with you guys so you can see some of the stuff. Ross, you have a charger by chance? So you'll see here, this is just many examples of many different things that, we did, or that I did. I filmed this at a later time, and I'm just going to go through a ton of different ways. And basically the name of the game is load single leg as much as you can, because say I was able to hold a 40-pound kettlebell in my hands, and that was where my pain threshold was. But if I held an 80-pound kettlebell and I tried to do a squat, it would hurt. If I do exercises on one leg, I'm able to load that one leg with a higher percentage of my 1RM if I'm holding the same amount of weight. So I did tons and tons and tons of single leg exercises during this time frame. So I'm just going to give over some examples of them. These are different posterior lunges. We filmed these the other day. These are with a landmine. We'll probably make a video regarding these a little bit later. But again, single leg exercises is the way to go if you're not able to hold the amount of weight that you would need because of pain. Now, some different modifications that we did when I eventually got back into barbell deadlifts, which I want to say wasn't about till a month in. Hey guys, I think we're back. Let us know if you guys can hear or not, okay? I think, I know it's about a 15-second delay, so I'll wait until we see some comments back.
Let's find out where we left
Awesome.
off.
Yeah, let us know where we left off. I think the screen share overloaded the internet. So let's see, let us know where we left off and we'll go from there.
Go ahead and pull up your stuff here.
I get it. Oh, I get it.
Single leg exercises.
Single leg exercises, okay. So in recap, the single leg exercises, they're important because you're able to load more weight on that one leg than doing double leg exercises. So I did a lot of things like single leg RDLs, a lot of lunges, a lot of split stance lunges, a lot of step ups, a lot of curtsy steps ups. I don't know if you guys saw our Instagram story yesterday, but I love leg day. I used to hate leg day. I thought it was the absolute worst. I hated how I felt after it. I was always so sore, which I am today. But it's actually the most fun. There's so much more movement variability you can do with leg day. There's so many different planes of movement, so many different ways to load, so many different ways to add steps, add tempo. Just so much more you can do with legs that really makes it fun. So basically, yes, if you're having issues, load up single leg movements. Now, when it comes to getting back into deadlifts, I didn't actually deadlift till about a month in. So continually bending forward, I did not wait to even attempt to load a flexion pattern, which is me bending forward, until I could bend forward without discomfort. So once I was able to bend forward throughout my normal day without discomfort, then I started to slowly load a flex position. So the way I did that was pretty simple. I would bend forward and maybe hold a little weight for 5 seconds, hold a weight for 20 seconds, hold a weight for 30 seconds, hop on the Romanian chair and just hold myself there for a little bit. And again, I was working up into my tolerance. Now this is about 3 weeks in now, mind you. We're past the acute phase of pain, and now we're in the phase where we have to slowly start loading it. So there might have been days when it was a little bit of discomfort, maybe a 2 out of 3 out of 10, and that's okay. But again, you have to be your own guide and know that I'm loading myself. Okay, I'm going to go to 2 out of 3 out of 10. I stop when it reaches that point, but then I have to see how I respond. How do I feel later that day? More importantly, because it's a disc issue, in the mornings were my painful time. How did I feel the next morning? The next morning felt really, really shitty, which twice during the times I was loading myself, it did. I knew I did too much and I had to scale back. And that's why it's really important that you have to work in small steps and not just jump the gun and just say, oh, my back's feeling great now, I'm going to go to barbell deadlifts. That's not where you go. You do these isometric loads that I talked about first. And even getting back into deadlifts, I did hex bar deadlifts before even barbell deadlifts. I think I posted a lot of that on the story. It's a little bit less trunk flexion, a little bit less on the erectors. I also squatted before doing deadlifting. I'm a high bar squatter, so not a low bar squatter, so it's not as much trunk flexion. So I did I didn't even start with the barbell. I started with kettlebell squats, goblet squats again. And then I went into an actual barbell back squat, started just the barbell, slowly worked my way up. I think the first day I barbell back squatted, I only did 95. The next day, I think I went up to a plate, 135, and I just slowly loaded it that way. You have to load them progressively to give your back and really your brain get it used to these loads you're getting and get it used to saying, hey, this is not supposed to hurt. The inflammation is done. Let's slowly get yourself and get your tissues back to where they're moving. Do I have any videos of that? I showed the deadlifts. Oh, yeah. Hip thrust. I started getting into hip thrust, I want to say, maybe like 3 weeks in or something like that. And when I was doing hip thrusts, this is kind of what I had to do, actually. I'll drive. Thanks, guys. Sorry, guys. I actually had to stack them up on a small little block like this. What's weird too, just the little amount of flexion at the bottom of the hip thrust was agitating me the first day I did this. So just putting them on these little, I think these are on like 1.5 inches, just because they're soft, it might even be less than that. But just adding that little bit of riser allowed me to be able to go full depth and to tap the weights at the bottom and to go back up. And these are all things that are smart modifications. When it comes to rehab, it's all about smart modifications to A, your day-to-day activities, and then B, your training to get you back. There are many times when doing specific rehab exercises are very important when we know that there are impairments. But when someone has an acute injury like myself, it was literally a disc injury, It's not necessarily that I had an impairment that's causing it. It's like I was stupid. My ego got to me and I loaded it way too much that one day and then did 1 arm cleans 2 days later. So that's a programming error on my fault, not anyone else's fault. I'm going to turn the screen share off now, I think. When I go to chest day, my chest day was largely unaffected. There was nothing that I had to change for that. When it came to back day, I wasn't able to do any bent over rows. That was way too much load on my back. So instead I did bench supported rows, which I should have left the screen share on, which I can show you guys. So instead of doing stuff like this, which is a ton of load on my back early on.
Yeah.
So I avoided stuff like this, okay? And this is, again, before I was deadlifting. And instead I opted for bench supported rows, which are here. I'm doing them with dumbbells here because this bench doesn't allow a barbell to go underneath, but in my opinion, a barbell is a lot easier to do an exercise like this on. And again, if you can't get it all the way to the bottom, support it with a step. But this is a way that I don't have to use as much back activity to still perform my rows. Okay. Where am I now? Now, note too that there are times in your rehab process when things don't go right, when it seems like you've hit a wall or it seems like you are starting to step backward. It is very, very common. Something I like to tell people in the rehab process is this is where we're starting at 0% of your functional capabilities. And we are going to here, 110%, not 100. We're going to get you back better than you started. It's not a straight line up. It's never a straight line up. It looks a lot like this. It's a lot of up and downs. And there may be some times when it's a huge down, okay, which I experienced about a month and a half in. I was back to deadlifts. I was back to back squats. I wasn't doing anywhere near the weight I was doing. I was probably only, I was deadlifting like I was probably at 2 plates at the time. And I would work out in the morning. I kind of went through faster my warm up. My hips felt a little stiff, but I knew I was short on time. I'm sure many people are when they go to the gym. And I started my deadlifts, and it did not feel right on some of my working sets, but I did not learn anything from my first injury. And I still did one more set. I didn't have an instance where I knew I hurt it, but I was like, okay, I should stop now. So I only did 1 over when I started to feel it. And then the next 2 days after that was pretty painful. But luckily it only lasted 2 days. So I need to learn from that. And I hope you guys do too, but don't let ego get the best of you. Just because I knew in my head, oh, things are going well. Things are moving well. I was just doing, 2 plates and some last time. How come at I think I was only at 155 or 175. How come it's hurting at 175? Or should I have just stretched my hip a little bit more to make it feel a little better? Because I already knew it was tight. When you are rehabbing, you have to respect these things, and you have to respect your body. Okay, the body is magical in the way that it heals, but you do have to respect it. So please do that. And now I'm at least 3 months out. I've been back to full deadlifting, full back squatting, no issues at all. Main moral of the stories. I think I'm just kind of went on a tangent. Essentially, don't be afraid if you're in back pain. It's a rehab process. It's a slow journey, but it is a journey back to your full functions, and you will be able to do the things that you want to do afterwards, but you have to be smart about it. Ideally, go see a PT in person if you can, who's going to help guide you and tell you what loads are okay and what loads aren't okay. One of the most important things is knowing which type of pain is okay, because you do have to load tissues once you're beyond that acute inflammatory phase. It's the only way that A, they're going to get better, and it's the only way that B, your brain is going to let you say, hey, it's okay to have these loads on yourself. So you do need to load things after they've been going on for a while and that acute inflammatory phase is over.
Good. Yeah, it's up and down. I think that's what I literally tell people the first day that I meet them. When people come in, they're dealing with a lot of pain. We're during one of the first follow-ups that they were having a really good day, and then maybe they had a couple bad days. But I think Mike explained it really well. There's just ups and downs. And unfortunately, that's the case. But at the same time, if you understand that, you recognize that, and then you're able to have an answer for those bad days, I think it can just help provide some reassurance. because if people just don't know that the rehab process is up and down, and then they have bad days, they kind of freak out.
Yeah.
And they're like, what do you mean now I'm getting worse? And it's like, no, it's just sometimes there's good days and there's really good weeks, and then sometimes there's just bad days.
It's part of trusting the process.
Yeah.
If you're committed and you feel like you have good control with the help of yourself or your clinician, whoever's in charge of your plan of care, you have to just be committed to the process. That's the biggest thing. A couple of things I wanted to reiterate, or did you want to go within your thing?
Yeah, so I mean, I can open it up now and answer a couple questions. If everyone was able to take a look at the back article that I posted that's on PeerWell, we can start letting some questions file in, and then I can pick a couple, and then we can talk about what you were thinking.
All right. In the meantime, a couple of things I wanted to reiterate. Mike brought up a couple of really good points I wanted to go in more detail with. The first one is going to be just the empowerment, where the fear of the pain itself oftentimes is more limiting than the pain itself, because what happens is you're afraid of moving and afraid of hurting or damaging whatever tissue it is that you already hurt. So part of it is understanding what's going on. And I use the analogy of the alarm system. So if you're at home and an alarm system starts going off in your house, you're going to think the worst. You're going to think someone's breaking into your house, about to steal everything in your house. That's just instinctual. But what happens is if you walk out of your room, go check out the front door and see that it's your brother, you're not going to be afraid anymore because you know who it is. So if you know what's causing your pain, there's a sense of empowerment and power that you have over your body that will decrease your fear. And so that fear of moving decreases a lot more after you kind of understood that part. So that's one thing. The other thing is understanding tissue loading. So basically what happens, and what happened to Mike, is that he has this tissue tolerance. This is Mike's back. This is how much load that he can tolerate right here. What happened with the deadlift that he did was that the demand was a little bit farther than his tissue capacity. And that's what causes injury. Whenever the demand is greater than that tissue capacity, that little bit of extra demand is going to cause Mike to have something give, whether it's his muscle, it's his disc, whatever it is. So what happens is his capacity now goes down because of this injury. And so what you want to do initially, looking big picture, is start with low intensity, high frequency. So you want to keep the intensity of exercises low now that he's down here, and just move a lot throughout the day, whether it's walking or it's little minor movements that you do within your pain-free tolerance. And then as your tissue capacity increases, this happens for Mike. It wasn't necessarily that he was weak, but for him, he was letting his tissue repair. So as his tissue repairs and regenerates, his tissue capacity is going to start going up. And so from there, his intensity of exercises can also increase. So that's something that as long as you understand that part too, you can kind of understand, okay, well, as I'm getting stronger, as my tissue heals, my capacity for exercises increases, so I can start doing more and more. And
I think there's two questions that we can address. Jennifer as well as Fernando, they both asked questions about they hurt their back, they think it could be disc related, but in all reality, both of them want to get back into the gym, and they're asking some advice as to how to get better, and to even for Fernando here, he wants to know how he can avoid surgery. So I'd say, number one, you two are already taking steps to getting better, and that's joining this webinar and educating yourself on low back pain, as well as Mike shared the story of how he got back into the gym and got back to lifting weights like he wanted after a disc injury. So number one, like I said, is educate yourself. Maybe trying to find out, is it disc, is it something else, or maybe you leave that up to someone, a healthcare practitioner, to really figure that out. But regardless of exactly what's going on, the ultimate goal is get back to the gym and get back to lifting and working out pain-free. So you just got to start moving. And again, I can copy this link because we may have lost it when we went back offline and then came back online. But here's an article that I wrote for PeerWell, and it sort of takes you through step-by-step process as to how to get back to doing what you like to do after dealing with some low back pain, regardless of what it is. And it's a starting point, like I mentioned in the beginning of the webinar. So number one, you just got to get moving. Like Mike said, whenever he bent over, whenever he went to flexion, it really bothered his back. So sometimes you just gotta stop poking the bruise. In Mike's case, it was bending forward. Every time he bent forward, it was like poking a bruise or picking a scab. Sometimes you just gotta let things heal, and that just purely takes time. And even us as physical therapists, we can be hypocrites. I know myself, I can be very impatient sometimes. But I have to be better about that with myself. And I educate my patients that it's just about getting better, and it takes time for things to heal. And then you just progress your movement. So Mike, he went through lifting. He shared some modifications with you guys on what he was able to do to still lift and work out and do the things that he liked to do and move, but without it really causing his pain. Anything that you would want to elaborate and touch on, Mike?
The funny thing with that is there's a joke that people say in terms of the ear wiggle technique, because initially you got to let time take its course, like we're saying. Regardless of what a therapist may do, the patient is going to get better as long as they don't keep picking that scab, like Craig was talking about. So if I start wiggling your big toe and you start getting better, you're going to think it's because I'm wiggling your big toe that you're getting better. But in reality, it's actually time itself. So you're going to keep coming back to me and have me keep wiggling your big toe or wiggling your ear or whatever it is that I'm doing. And that's not the reality. The reality is that natural healing process is taking its course. So that's part of the education process.
Back to the disc things too, just going on this, Doug Collins, you mentioned something about, I slipped a disc a year ago. I think that's involved. How do I go about fixing this? Discs do heal. Know that they do heal. So when you have a disc injury that's acute, the pain that you feel is due to the inflammation around the disc that is causing all your pain, not that the disc itself is causing your pain. And why you start to feel better after peak inflammation, 24, 48 hours, why you start to feel better as days go on, because the inflammation decreases. That's why if you have an inflammatory condition, you take an NSAID, a Tylenol, leave, and it feels better because it's cutting out the inflammation. So know that as time goes on and you start to feel better, that disc bulge, one of two things. We do know discs do heal. There are some studies that have shown that discs have literally reabsorbed.
Literally within a year, one quick stat is after a year, 66% of discs do reabsorb.
Yeah. And even if they don't reabsorb, they're not necessarily painful anymore because there isn't any inflammation there. So I never got an MRI after my disc injury. I'm now
Doesn't matter.
3-4 months out. I bet if I got an MRI now, the disc bulge would still be there, but I'm not in pain because it's not an active inflammation. So know that just because you had a disc bulge a year ago or 5 years ago, whatever, it doesn't mean that you're going to chronically be in pain because the inflammatory process isn't still happening. Unless, like Craig says, you're still picking at the scab and you're still doing things that irritate it, then maybe it might be. But know that that disc bulge is not forever. And the pain associated with it is not forever.
Yeah, I have a quick funny story about a patient that did come in one time telling me, hey, here's my MRI. I don't feel anything, but apparently I have back pain, which is this is the classic story where this guy feels nothing and you can't tell someone they have pain. You have pain or you don't have pain. This is what you're reporting subjectively. No one can tell you that. So that's something that's an instance where the MRI itself created fear in this guy's mind to the point where he's looking for help. So one other thing I wanted to add too, in terms of squatting, because I've herniated a disc as well. My mechanism of injury was via a squat, and I just went too low in my squat. Actually, if you guys check the post from yesterday on Instagram, it talks about how externally rotating your hips, where you're pointing your feet out a little bit, will take a little bit of load off of the back, so you get less activity with the erector spinae muscles and multifidus muscle, and it'll increase load of the glute muscle. So it'll put a little more load on the glutes, a little less load on the low back. But either way, I was going deep into my squat, and initially at that bottom of the squat position, I heard something go, and I felt it right away. I dropped, and I was in my garage. I had no one around me, and I fell to the floor. I couldn't move. It was very, very disabling.
What?
This was in PT school 2 years ago. Very disabling. I couldn't move. I couldn't do anything. My phone wasn't in walk. I couldn't reach my phone. And what happened is I just laid there for 20 minutes, let myself just relax, focus on my breath, and then I was able to move. Pain was terrible for a couple weeks. Usually they say around 21 days is when most HNP, which is a herniated disc, starts to reabsorb or starts to get better. But again, it really depends on the severity of it. But either way, what I wanted to say with the squats itself, in my mind, there's 3 different ways of squatting. And I'll break it down from most risk of injury to the least risk of injury. So the highest risk of injury with a squat is by rounding your back through the motion, where you're squatting and you're going into lumbar flexion, and as you extend, you're going into lumbar extension. So that's the highest risk of injury. The second highest risk of injury is by keeping a flexed spine throughout the entirety of the movement, where you keep your back rounded into lumbar flexion as you go down and as you go up. Think about those powerlifters or those guys that lift those big atlases. Those guys have to stay rounded the entire time. So that what they do is they round their lumbar spine, they pick up the heavy ball, and then they lift themselves up while keeping the spine round the entire time. They don't extend as they come up. They lift with their legs, and then they round their back at the end of the movement. And then the least risk of injury is by keeping a neutral spine throughout the entire movement. So you always want to shoot for this, for that movement pattern, but we talked about this last webinar. Even if you don't visually see a change in the lumbar spine as you go into a squat, oftentimes there is still some motion that goes in there. So you want to make sure to keep your lumbopelvic control as good as possible. And if you don't exactly know what that means, check out that article that Craig just posted about the 13 exercises for low back pain. And there's a couple of good exercises on lumbopelvic control because you want to really be able to dissociate the two.
Okay, and let's see. I'm going to take a look at some of the questions. A lot of the questions are filing in right now. Russian twist.
Someone asked about the TA. The TA is transverse abdominis, which is a deep core muscle. When people use the terms hollowing versus bracing, hollowing is basically describing using the TA, which is a transverse abdominis, and the bracing is described for the entire core, being the external and internal obliques, rectus abdominis, and transverse abdominis. So do I use TA activation as a cue for engaging the core? With higher level people, I typically do that. I don't use that on everyone and anyone. It depends on the patient population that I'm talking about, or that you're talking about, or that you're seeing. But I will use that from time to time. They found studies where there's a delayed reaction with TA activation. Paul Godges came out with a lot of stuff. I think it was back in the 90s that most of his stuff came out. So there's a correlation with poor activity of the TA and low back pain. So that's where that idea came into place.
So here's a question from Doug, and it looks like you asked this question earlier. And I think this will I think all 3 of us can agree moving forward with these webinars. It's really only a couple of sentences here, but Doug is asking, he has pain with a certain exercise, certain part of the back. You got to realize, we're really limited in what we can do here. So I know that you mentioned you've tried lots of rehab, but maybe see a new PT, really get a full assessment, get a real full evaluation. It would be a disservice to you from us to try to say that we know what's happening and to actually what to do. We get a lot of messages on Instagram, on Facebook, asking for these similar types of help and whatnot. And it's just not fair to you for us to say that we know what's going on without even seeing you, knowing how you move, taking more questions. And that's why you're dealing with pain for a long time. Go see someone. Go get it taken care of.
There's a question there. That's good. That's a really good point, Greg. Yeah, go see someone in person. It's online. You can't. It's a disservice.
Yeah, if you really can't find someone, email us your zip code, and what we can do is look for a experienced clinician that we would potentially trust within our network, or we can look around and try to give you a better idea of who we would recommend. So just email us your zip code.
David asks, I've heard about distraction therapy. How does that work and how good is it? Distraction therapy, if it is what I'm thinking it is, it's like distraction tables or inversion tables. There's a very small subset of people that it helps. I'm not a fan of it for discs because there's a rebound effect that I know people get when they go on it. I'm not the biggest fan. Some people use it a lot, some people don't. Back pain is one of those things that, like I said, education is the most important thing, and staying active is the most important thing. We still don't know. It's different than other regions in the body where you can pinpoint structures and say, this is what's causing your pain. There's so many psychological components that go into low back pain, and staying active, being unfearful are the most important things, regardless of what type of back pain you have.
I mean, first year PT school, I hurt my back after it was a week of snowboarding, golfing, and I did something weird weightlifting with Mike. We're actually doing a unilateral overhead shoulder press, and I was coming down on the right, and I just heard this loud click in my back, and I was like, that's not good. And I was doing PT. It was like the end of our first semester, first year. It was a stressful time. We were dealing with exams, and my back was just killing me. It was terrible. It got worse with studying. It was always worse with stress. And then exams week came and gone, and then I was just walking, and my back pain went away. And whether it was a matter of just timing, like we've talked about, which most of the time it is, it's just timing. Things heal. But stress plays the biggest role. Like whenever patients come in and things aren't going as well, my number one thing is I ask follow-up questions. Well, how's everything outside of here? How's work going? How's life at home going? And I'm not saying that every single time the person's dealing with stress, but a lot of the times it can feed into it.
Yeah, I've seen a study. I don't know how rigorous the study was, but finding correlation with low back pain. And the strongest correlation was actually psychosocial issues, being stress, anxiety, depression, being the strongest correlating factor to low back pain, more so than even your MRI showing a disc herniation or a degeneration, which just shows you how common back pain is correlated with these psychosocial behaviors or psychosomatic behaviors. So something to think about. And if you don't address the cause of the issue, and stress, anxiety, depression is the cause of the back pain, then you're never fully going to repair, regenerate, or whatever it is, recover from this process, because you have to address the cause. These secondary interventions that you may be addressing, or secondary impairments that you may be addressing, are not going to fully allow you to get back to full function.
Yeah, so Nathaniel asked, any recommendations to enhance one's capacity to recover? Just goes on the 2 points that you guys meant. Look at things outside of your direct physical things that you're doing, your stress levels, your sleep levels, your nutrition. Sleep.
Mm-hmm.
Yeah, look at things outside of just maybe the more quote-unquote obvious things, even though these things are really obvious. I'm only getting 4 hours of sleep because I'm really stressed because I have a paper and I have a deadline due.
You're in trouble.
That's a big reason why you're going to start feeling pain. You know, your threshold's lower. Your threshold of pain is lower because you're
more sensitive.
out.
Yeah.
So
your body's not regenerating, recovering as quickly. You're more at risk for discomfort.
Yeah, I honestly tell people that if it's between coming to PT and sleeping, like sleep, I honestly think that people would get better if they slept more and they took care of themselves versus being stressed out, trying to force things. And I mean, yeah, it seems really simple, but sometimes it's the simplest things that we overlook. And I mean, a lot of what we do is just education. We really
100%.
do.
Look what we're doing right now. This is pure
Yeah.
education. We're not touching anybody.
And we love this stuff. I mean, I think anything in the world, you go to someone that is an expert in a field to help tell you what's going on when you're dealing with an issue or a problem. And then when you get that reassurance from that person because they have expertise and they can give you answers, get you to calm down and relax. So,
Yeah, it's part of knowing what's going on. That gives you a lot less of a reason to fear this pain that you have, as long as you trust that person.
Yeah. Going 2 questions. One's from Andre Hoff, who's a PT student in Brazil. Talked about that.
yeah, that's a good looking question.
It says, I'm a PT student in Brazil, and the huge majority of my teachers say that the X-ray and MRI are of high importance to diagnose the patient issue. Almost in all cases, they say they would ask for imaging. I myself had a crisis of low back pain, and the first and second things that the psychiatrist asked was for my X-ray and MRI. Does it only happen in Brazil that professionals seem to be so dependent on imaging? And the answer is no. I was in China for 4 months studying with Joe Godges, for those of you that know who he is in the PT industry, PT world. We did a lot of physician shadowing, working with the physicians probably once a week with their more complicated cases. And I think one of the craziest and crazy thing. One of the really interesting things that happened one of the times I was there was they were all going through one of the X-rays of one of the patients who had this issue, and all we did was prone press-ups, which is what I was telling you guys earlier when you're doing like a little cobra. He responded well to it, so we had him do it like 3 sets of 15, and then all of a sudden he had no more pain, and all the people, all the doctors, they were all physicians, all the top physicians, all looking around like, what's going on? Like, he was in so much pain. Look at the MRI, look at the X-ray. Like, how is that possible? You know, because it's not all based on imaging. So no, it's not only in Brazil. It's for the most part everywhere else in the world. This is all new.
Some crazy
I think-
stories from China.
Yeah, seriously. I think for learning purposes, people try to categorize things by diagnosis, which makes it easier to for learning purposes, of course. But the way that the CPG is created is by like movement coordination impairment, mobility deficit, radiating pain, referred pain, and that's what we as rehab specialists use more so than purely based on a diagnosis.
And that's clinical practice guidelines for anyone that's not a PT. That's what Arash means by CPG.
Mm-hmm.
And then here's another question. Again, from the top, Virginia, we sort of responded to another individual earlier. Just went Doug. Doug had a similar question, and it was just very related to him, exactly what's going on, dealing with a lot of pain. I know you're trying to give us a lot of details, and you're looking for answers, and trust us, we would love to help you. We would love to help every single person in this room if we could. But we're limited with what we can do online with just a few sentences without seeing you, seeing how you move. So if any of you are in California, email us, come see us. We'd be happy to do it. But it would be a disservice to you to try to help you out without seeing how you're moving, without getting a more thorough background, and making sure that nothing else is going on. Because another thing that we haven't really talked too much about today, but like pain can refer from different areas. So back pain can come from different areas of the body. It can come from issues at the hip. It can come from issues at the knee and you're trying to offload your knee. It can even come from issues at your neck. But more importantly, there can be even bigger things that are outside muscles, joints, and ligaments that are worthwhile getting checked up. And again, it's really smart to get checked out when you're dealing with something for a really long time and it's a lot of pain. And we just want to make sure that everyone gets better. So cool. That's our big thing.
All right, guys, it's coming up on an hour. We didn't intend for this to be this long, but glad you guys stayed engaged and glad you guys had a lot of questions. Let us know if there's any other questions that you guys wanted to address. We'll be doing this once a week. So recapping, we'll be coming out with the Prehab membership pretty soon, which we'll be doing this weekly to answer any questions that you guys have and go more in detail with our posts. Today we didn't have time to do that. We focused on Mike's rehab process with his disc herniation, but we'll start doing that more. It's whatever you guys want, really. So we'll start doing that in the future. And yeah, thanks for joining us.
Shoot us an email if you guys have any feedback, ways that we can improve this experience. Sorry for the connection delay earlier. I think we got it solved though.
Yeah.
So
Yeah, we're still learning, but we really hope that you guys enjoy these webinars.
Yeah.
Yes, there will be a cost to the Prehab membership. Within this week, you'll be able to see the different types of memberships that we're offering. It's purely based on time. So either you can sign up for a month, semi-annually, or per year. And based on that, it'll be a different price point. But we really plan on hammering away the education here. So there's a lot more of this to come, and we hope that you enjoy it.
Thanks, guys.
have a good day.
See ya.